Hi guys, the next topic that I'll explain to you is sideroblastic anemia. Though it would be having varying reasons, I will first try to explain to you why does it actually develop and why is it that you have increased serum iron and increased serum ferritin in this condition. At the moment, what I'm sketching before you is a representation of a normoblast. The blue dots that I've shown here are iron deposits which are going to be utilized for red blood cell synthesis. The normoblast is of three varieties, that is first a early normoblast, then an intermediate and then a late normoblast. Now I'm going to draw this normoblast once again before you. Remember, I'm discussing normal at the moment, but now you will notice that I have significantly reduced the amount of iron deposits here, and you can see that I've introduced a pink color because now hemoglobin synthesis has started. In fact, what I am teaching you at the moment is itself an MCQ, that in which stage of normoblastic development does hemoglobin appear. Then I want you to remember this information, that intermediate normoblast stage, there are three stages as I said. I'll just write captions EIL to represent early, intermediate and late, and it is the intermediate normoblastic stage when hemoglobin synthesis will occur and gradually this cell will start changing color from blue to pink. The cell that I've shown at the moment before you is having two colors, blue color and pink color. So pathology people will use the term polychromatophilic. Now this cell will give rise to a reticulocyte. I have changed the color this time to highlight that now hemoglobin is occupying majority of the cell and the nucleus of the cell is also disappearing by the process of pinkonosis. Subsequently, I have shown a routine biconcave appearance of a mature red blood cell, and what I've tried to highlight in this discussion is that the blue color is changing towards pink because hemoglobin is being formed and iron is being utilized. I will now explain an abnormality here. So compare the normal versus the abnormal one. The abnormality is that my patient suffered from TB, so I had to start him on ATT, and isoniazid, which is a primary bactericidal antibiotic, is also gonna damage the bone marrow. Well, what is the problem? Isoniazid will inhibit hemoglobin synthesis. So as I told you, hemoglobin synthesis begins inside the intermediate normoblastic stage. Now this step will be prevented. Because of this, what I'm showing in this diagram now is that there will be a formation of reticulocyte, yes, in this patient. The reticulocyte nucleus will also begin to disappear, but the bad news is because there was inhibition of hemoglobin synthesis, so this reticulocyte is still having this unutilized iron. The blue dots that I've shown here is iron deposits still present inside a reticulocyte. In you and me, the reticulocyte was appearing pink. There were no iron deposits because hemoglobin synthesis was occurring normally. But here this drug has put on the brakes. Therefore, even the red blood cell that will be formed in this condition not only will be relatively smaller, so microcytic hypochromic, but will also be having iron deposits present, whereas normally we don't see iron deposits inside the RBC. Well, from the pathology domain, this iron deposits inside the red blood cell are called as Pappenheimer bodies and are not to be confused or mixed with Howell jelly bodies, which will be single dots towards the periphery, whereas Pappenheimer bodies can be multiple and towards the center, though obviously you require special stains to differentiate between the two. I want to highlight that in sideroblastic anemia, the red blood cells that are formed are loaded with iron. Though size-wise they are smaller, they are microcytic, they are hypochromic, but at the same time, I want you to understand why hypochromic, because hemoglobin is not being formed. They are full of unutilized iron. Now, if you draw a blood sample of this chap and you test for serum iron, because the RBCs are loaded with iron, so serum iron will be increased. And if serum iron is increased, then gradually serum ferritin will also be increased. Please appreciate the fact that traditionally when you study anemia, the thought process is anemia should always have a less ferritin level, but I'm teaching you a peculiar anemia in which ferritin is increased, and that is the reason why this is asked in the exam. In fact, for management of this anti-tubercular drug-induced sideroblastic anemia, though there are multiple causes for sideroblastic anemia, this could be read even with myelodysplastic syndrome, but I want you to remember that especially the one that is seen with anti-tubercular drugs can actually be showing a mitigation. What I mean by mitigation is reduction of manifestations with vitamin B6. So lots of time you will also read about this MCQ, pyridoxine responsive anemia. That itself a very peculiar term. No, pyridoxine responsive anemia is, your answer would be the sideroblastic anemia that is seen with anti-tubercular drug isoniazid. So don't be under impression that it would be seen only with ATT induced scenario. It can be X linked also. So, I mean, genetics play a role in development of sideroblastic anemia. Then are drugs. One of the important drugs to be remembered over and above isoniazid is chloramphenicol. Yes, the same drug that you study for causing gray baby syndrome. It was earlier used in typhoid extensively, though now we obviously use quinolones. Then can be zinc toxicity. I hope you recall zinc deficiency causes enterohepatica, that is acrodermatitis enterohepatica, but zinc toxicity per se results in development of sideroblastic anemia. Then is lead poisoning as well. So he can give you any of the following scenarios. And yeah, I mean, per se, as I highlighted, it is Prussian blue as a stain that can be used to demonstrate the iron deposits there. So every time you see a slide of Prussian blue and see bluish deposits inside the red blood cell, Pappenheimer bodies are to be kept in mind. The main reason why we are studying this topic is to compare this with anemia of chronic disease. So now look at some fundamental differences that I'll say before you. I'm going to be talking about diseases like ulcerative colitis, rheumatoid arthritis, systemic lupus erythematosus, and Crohn's disease. In fact, I've highlighted in the literature of SLE that the commonest anemia that is encountered in SLE is anemia of chronic disease followed by autoimmune hemolytic anemia. Now, what is the problem in this case? The problem here is liberation of a product by the name of hepcidin. You see, hepcidin per se is a regulator of iron metabolism. This time what hepcidin, the regulator, is doing is it is inhibiting iron utilization from the stores. Please appreciate, earlier I was not saying inhibition of iron utilization, I was just saying inhibition of hemoglobin synthesis. But this time I'm saying hepcidin is putting brakes on iron utilization from the stores. You see, the stores are the ferritin stores that I'm talking about. So iron is not going to be able to come out of it. Therefore, first focus on the word inhibition of iron utilization. So therefore serum iron in the body of these patients will be lesser. Why lesser? Because it's not going to be able to come out. Therefore the stores will remain unutilized. I repeat the word, the store serum ferritin will remain unutilized. So there are two possibilities: either they will remain normal, or because input, because he's eating food also that will be having iron. So because the stores are getting an input but no output, ingress is there but egress of data is not there. So therefore the values will continue to rise of serum ferritin. The peculiar thing is, again I'm teaching you anemia in which ferritin is more, but still I'm saying anemia. Why? Because ultimately if iron can't be coming out, it can't be utilized for hemoglobin synthesis. So the speciality of anemia of chronic disease is it can also have an increase in the value of serum ferritin. But how is it different from sideroblastic anemia? Serum iron levels. In sideroblastic anemia, I was teaching you that serum iron is going to be elevated. Why? Because there is iron-loaded red blood cells. But this time, it is rather inhibition of release from the stores per se, which is responsible for decrease in the value of serum iron. Plus, the type of anemia seen here is normocytic normochromic. You might say, sir, you have discussed or pathologist has told that anemia of chronic disease is microcytic hypochromic anemia. Yes. Microcytic hypochromic anemia can develop in anemia of chronic disease and is a late manifestation. Initially, it is normocytic normochromic. So in single best response, your answer will be normocytic normochromic. In multiple correct response, anemia of chronic disease is both normocytic normochromic as well as microcytic hypochromic. Well, normocytic normochromic anemia is again something that my students ask me that, sir, why are you calling it anemia if everything is normal? Well, I hear the problem is not with the size of the cell or the amount of hemoglobin inside the cell. The problem is with respect to the RBC count, no? In normocytic normochromic anemia, it is RBC count that is lesser. And why can that be lesser? Well, it could be deficiency of erythropoietin in a patient of chronic kidney disease due to multitude of reasons. It could be autoimmune hemolytic anemia, which has been described for SLE or for chronic lymphocytic leukemia or even Hodgkin's, non-Hodgkin's lymphoma, where warm kind of antibodies have been discussed. Even anemia of chronic disease that I just highlighted before you related to hepcidin is having normocytic normochromic anemia. In contrast, if he says what are the causes of microcytic hypochromic, then you know this from pathology. I'll not write the causes, I'll just mention the mnemonic SITA, that is sideroblastic anemia, iron deficiency, thalassemia, anemia, chronic disease, and including lead poisoning as well. So I'm just writing SITA here. That is lead poisoning can be written. I mean, though lead poisoning is one of the causes of sideroblastic anemia, in a MCQ, just to increase the choices, he can write that. What are the causes of macrocytic anemia occurring in a patient? Even a biology student knows that macrocytic anemia is caused by B12 and folic acid deficiency. So you guys have to tell me causes beyond B12 and folic acid. Causes beyond this that you need to remember are chronic liver disease. When I've discussed the thyroid topic, I have highlighted hypothyroidism having macrocytic anemia, and these are two important ones, and then aplastic anemia. Causes of vitamin B12 deficiency themselves can be incorporated in the question. You see, why would you be having B12 deficiency? That's itself a scenario that he can actually put up as options. So when it comes to especially vitamin B12 deficiency, it means ileum is damaged. So he can talk about bacterial overgrowth syndrome, which may be written as small intestinal bacterial overgrowth, SIBO or BOS, bacterial overgrowth syndrome. Then intrinsic factor is important for B12 absorption. So he might write type A gastritis among the causes present here. He might mention regarding a rare kind of a worm, that is Diphyllobotrium latum, right? That is the fish tapeworm, which is a cause of megaloblastic anemia, B12 deficiency, quite frequently asked. Or from biochemistry, he might mention regarding orotic aciduria. You see here, it is a defect of pyrimidine metabolism, because we need ultimately for formation of DNA, various products, and in this case, in orotic aciduria, that's the metabolites for DNA synthesis is not very much present. Reason for folic acid deficiency can range from pregnancy to usage of antiepileptic drugs to diseases of the jejunum. I hope you recall diseases of the jejunum can be like, for example, celiac sprue, tropical sprue, and though celiac sprue mainly will be having iron deficiency also because duodenum is involved, but then the both varieties of sprue also have concomitant folic acid deficiency. This is a recap of what you already know from your pathology classes, so nothing great about it. I mainly wanted to highlight regarding two anemias where we will be classically having an increase in serum ferritin. In fact, listen to this table: iron deficiency anemia versus sideroblastic anemia versus anemia of chronic disease, and I can just put them in a single table, and I'll try to do this under 1 minute. What I'm going to do here is put in the values of serum iron, put in the values of serum ferritin for these conditions, and TIBC, and this is not one MCQ, this could be multiple MCQs combined in one. You see, if you focus on the word deficiency here, serum iron will definitely be less, ferritin will also be less. TIBC you don't need to bother because TIBC is always inverse of ferritin. So the value of TIBC in this case will definitely be increased. Sideroblastic anemia, I drew a red blood cell before you that is loaded with iron. So I can call this a iron rich or iron loaded red blood cells. So because I'm using the word iron loaded, so therefore serum iron will be more, ferritin will be more, and TIBC you don't need to bother because it is always ulta inverse of serum ferritin value, so it would be lesser. And in anemia of chronic disease, it was hepcidin that was the game changer. It was inhibiting the release of iron. So if iron is not going to come out from its original site, serum iron will be less. The stores will either be normal or will be rather overflowing with the supply. TIBC values will obviously go opposite. Guys, you should be able to draw this table in the shortest possible time frame because they will say in a single question all are correct and they'll mix and match these values. Most of the time I have seen people messing up, though it's very easy, people messing up on anemia of chronic disease. There are two anemias that I taught you in this particular short lecture where ferritin values can be elevated, but the differentiation is on the value of iron, whereas iron loaded state versus inhibition of release of iron. So if you get the facts right, I mean, this table is not something that should take 2-3 minutes. It should be imprinted in your brain so well that when he says increase decrease in the question ना, तो वहां पे एकदम से pressure cooker situation हो जाता है. People tend to mess up in the increase decrease thing. तो जब भी मैं को comparison tables बनाता हूँ, you should always try to not passively listen but try to hand draw these tables with me. I mean, the crux of this discussion is that this table is to be self-made by you yourself in your handwriting, stuck up somewhere so that this becomes a permanent memory for you. Anyway, as I have always highlighted, doctors are supposed to have a photographic memory. I mean, you एक बार पढ़ लिया छप जाना चाहिए दिमाग में. हम कैजुअली पढ़ते हैं, बीच में मोबाइल इंटरनेट से डेटा आता रहता है तो वो एनर्जी खींच लेता है ना, एनर्जी वैम्पायर है वो हमारे लिए. So these are the details, guys, that I want you to remember for this topic, and mainly this concept of why, do you have increased serum ferritin, why do you have increased serum iron, sideroblastic is what I really wanted to highlight. And once you get the concept, remaining causes, etc., so you have studied even from pathology. Thank you so much for your patience and hearing me out.